You woke up this morning. You got out of bed. You walked to the bathroom, brushed your teeth, maybe started the coffee. Everything felt completely normal. Just another Tuesday. Just another routine morning in your 60s or 70s. But what if I told you that somewhere between putting on your slippers and pouring that first cup, your heart tried to send you a warning signal? Not dramatic chest pain, not collapsing to the floor, not the kind of heart attack scene you've seen in movies 100 times. Something far quieter. Something so subtle that 9 out of 10 people dismiss it as simply getting older. And here's what stops me cold as a physician. By the time that subtle warning becomes an unmistakable emergency, we've often lost our best window to intervene. The window where simple changes, maybe one medication adjustment, maybe a single lifestyle modification, could have prevented what comes next entirely. My name is Dr. Michael Carter, and over the past 15 years working with cardiovascular patients in their 60s, 70s, and 80s, I've seen a pattern that nobody talks about in waiting rooms. The earliest signs of serious heart trouble don't look like heart trouble at all. They look like fatigue. They look like aging. They look like nothing worth mentioning to your doctor during a rushed 12-minute appointment. But a study published in the American Journal of Cardiology tracked over 4,000 patients and found something remarkable. Those who recognized and acted on early cardiovascular warning signs reduced their risk of major cardiac events by 67% compared to those who waited for more serious symptoms. 67%. That's not a small number. That's the difference between a long, active retirement and becoming a statistic. So in the next 22 minutes, I'm going to walk you through 5 early warning signs ranked from commonly dismissed to genuinely urgent. And then, I'm going to tell you exactly what to say to your doctor to make sure you're taken seriously, because that conversation matters more than you might think. But right now, before we go 1 second further, I need you to do something. Drop a comment below and tell me, have you experienced unusual fatigue, shortness of breath during normal activities, or waking up at night feeling like you can't catch your breath? Just yes or no. Your answer is going to help me understand who I'm speaking to today, and it's going to matter very soon. Let me give you some critical context before we dive into the list, because understanding why these signs appear after 60 is going to make everything else make perfect sense. When you're in your 30s and 40s, your cardiovascular system operates with what I call margin for error. Your heart muscle is strong. Your arteries are elastic. Your blood pressure regulation system responds instantly to changes in position, activity, or stress. Even if something starts going slightly wrong, your body compensates so effectively that you never notice a thing. But here's what changes after age 60, and I need you to hear this carefully because this is the biological reality we're working with. First, your arterial walls begin to stiffen, not because you did anything wrong, not because you didn't exercise enough or eat perfectly. It's a natural process called arterial aging. Those vessels that used to stretch and flex with every heartbeat become progressively less elastic. Second, your heart's electrical system, the network of cells that coordinate every beat, starts developing what cardiologists call conduction delays. The signals don't travel quite as fast. The rhythm isn't quite as perfectly regular. Third, and this is the one most people don't know about, your heart muscle itself goes through a process called myocardial remodeling. Even without disease, even without blockages, the muscle fibers reorganize. Some thicken, some thin. The left ventricle, your heart's main pumping chamber, has to work slightly harder to push the same volume of blood. Now, in a perfectly healthy 65-year-old, these changes are managed beautifully. The body adapts. You might not run as fast as you did at 25, but you function perfectly well. The problem is, when you layer even mild cardiovascular disease on top of these age-related changes, a small amount of plaque buildup that a 40-year-old heart would compensate for easily becomes something a 68-year-old heart struggles with. A blood pressure elevation that used to be managed seamlessly now creates strain. And here's the critical piece. Your body still tries to compensate. It still tries to hide the problem, but it can't do it silently anymore. It has to send signals. Those signals are what we're about to discuss. Doctors call this the compensation to decompensation transition. It's the window where your heart is working harder than it should, but it's still working. It's managing. It's getting the job done, but just barely. And the signs that appear during this window are your body's way of saying, I need help before this becomes a crisis. That's the framework I want you to carry into everything that follows. Now, before we get into the first sign, do me a favor. Tell me your name and where you're watching from. I read every single comment and I genuinely want to know who I'm helping today. Let's start with the sign that gets dismissed more than any other on this entire list, and it frustrates me deeply because it's often the earliest warning your heart gives you. Unusual fatigue, not the tiredness you feel after a long day of physical work, not the sleepiness that comes from staying up late. I'm talking about a profound, unexplained exhaustion that settles over you after activities that never used to faze you. You walk from your car to the grocery store entrance, maybe 50 yards, and you need to stop and catch your breath. You fold laundry for 20 minutes and feel like you need to sit down. You have a conversation with your grandchild, nothing strenuous, just talking, and afterward you feel drained. And here's what happens in almost every case. You tell yourself, I'm just getting older. This is normal. I'm 67, not 27. Of course I'm more tired. But let me tell you what's actually happening inside your cardiovascular system when this type of fatigue appears. Your heart's primary job is to pump oxygenated blood to every cell in your body. Your muscles need oxygen to contract. Your brain needs oxygen to think clearly. Every organ system depends on adequate blood flow to function. When your heart starts struggling, when it can't pump quite as efficiently as it used to, the first thing your body does is prioritize. It shunts blood away from less critical areas, your muscles, your digestive system, even parts of your brain, and redirects it to the most vital organs. The result? You feel tired. Not because you're lazy, not because you're out of shape, but because your muscles are literally receiving less oxygen than they need to function optimally. A study published in the Journal of the American College of Cardiology followed 2,400 patients over age 60 who reported new-onset unexplained fatigue. Within 18 months, 42% of them were diagnosed with significant coronary artery disease or heart failure that had been developing silently. 42%, nearly half. Here's the symptom pattern most people completely misread. You wake up feeling okay, maybe a little stiff, but okay. You have your morning coffee. You feel almost normal. But by 11 a.m., after doing nothing more strenuous than light household tasks, you're exhausted. Not sleepy. Exhausted. There's a difference. Sleepy means you want to nap. Exhausted means your body feels heavy, like you're moving through water, like every action requires triple the effort it should. You sit down. You rest for 20 minutes. You feel slightly better. You get up and do another simple task, and the exhaustion comes roaring back. That pattern, that specific pattern of disproportionate fatigue followed by brief recovery, followed by rapid exhaustion again, is your heart telling you it cannot maintain adequate output during even mild exertion. Now, I'm not saying every instance of fatigue after 60 is a heart problem. Thyroid issues cause fatigue. Anemia causes fatigue. Depression causes fatigue. Sleep apnea causes fatigue. There are dozens of potential causes. But if this fatigue appeared somewhat suddenly, if it's worse than it was 6 months ago, and if it's specifically triggered by physical activity that never used to bother you, your heart needs to be on the list of suspects, right at the top. The action step here is simple, but it requires you to track something. For the next week, keep a small notebook. Write down what activity you were doing when unusual fatigue hit. Write down how long it lasted. Write down what made it better. Take that notebook to your doctor and say these exact words. I'm experiencing new onset fatigue disproportionate to my activity level, and I need you to evaluate my cardiac function. Don't let them dismiss it. Don't let them say, well, you're 65. You're the expert on your own body. If something changed, something changed. Insist on answers. If you're still with me and finding this helpful, take 2 seconds and type the number 2 in the comments. It tells me you're watching, you're engaged, and this information is landing. Let's keep going. Here's one that sneaks up on people because it doesn't happen during the day when you're active and alert. It happens at night, in the quiet, when you're trying to sleep. You lie down in bed. You get comfortable. You're ready to drift off. And within 10, maybe 15 minutes, you notice you're having trouble breathing. Not gasping, not choking. Just a sensation of not being able to get a full, deep, satisfying breath. So what do? You prop yourself up with an extra pillow, maybe 2. You sleep semi-upright. The breathing difficulty eases. You fall asleep. Problem solved, right? Wrong. Problem masked. Let me tell you exactly what's happening when you can only breathe comfortably while propped up and why this is one of the most significant early warning signs of heart failure. When you lie flat, gravity stops helping your heart. During the day when you're upright, gravity assists blood return from your lower body back up to your heart. Your heart works, but it has help. The moment you lie down, that gravitational assistance disappears. Now your heart has to do 100% of the work, moving blood from your legs, your abdomen, everything below your chest, back up to your lungs, and through your cardiovascular system. In a healthy heart, this is no problem. The muscle is strong enough. The pumping efficiency is adequate. You lie down and nothing changes. But in a heart that's starting to weaken, lying flat creates a challenge. Blood begins to back up in the veins leading to your heart. That backup creeps into the vessels in your lungs. And when fluid pressure builds up in your pulmonary vessels, the tiny air sacs in your lungs, the alveoli, start to accumulate fluid. Not enough to drown you. Not enough to cause obvious lung sounds that a stethoscope would catch immediately. Just enough to make breathing feel harder. Just enough to make you feel like you can't quite fill your lungs. Cardiologists call this orthopnea. And it's a classic textbook early sign of congestive heart failure. Here's the other version of this that people miss entirely. You fall asleep fine, no problem breathing, but you wake up at 2 or 3 a.m., gasping slightly, feeling like you need to sit up or walk around to catch your breath. After a few minutes upright, you feel better. You go back to bed. It happens again a few nights later. This is called paroxysmal nocturnal dyspnea, and it's the nighttime version of the same problem. Fluid builds up in your lungs while you sleep. Your body eventually sends a panic signal that wakes you up. You sit upright, gravity drains some of that fluid back down, and you feel relief. A study in the European Journal of Heart Failure found that patients who reported either orthopnea or paroxysmal nocturnal dyspnea had an 8 times higher likelihood of having measurable left ventricular dysfunction on echocardiogram, even when they had no other symptoms during the day. 8 times higher. Here's what I need you to understand. If you are sleeping with 2, 3, or 4 pillows, not because of acid reflux, not because of sinus issues, but because you genuinely cannot breathe comfortably when flat, your heart is struggling with volume management. This is not just aging. This is a mechanical problem that will get progressively worse if not addressed. The fix might be as simple as a diuretic, a water pill that helps your body eliminate excess fluid and takes pressure off your heart. Or it might require imaging to determine if there's valve disease, coronary blockage, or weakened heart muscle. But you cannot know until you tell your doctor. And here's how you say it. I have orthopnea. I cannot lie flat without difficulty breathing. I need an echocardiogram and a BNP blood test to evaluate for heart failure. Use those words. Be specific. That level of detail gets you taken seriously. Now, before I show you the next warning sign, if this information is giving you clarity you didn't have before, hit that like button. It genuinely helps more people find this content. And tell me in the comments, how many pillows are you currently sleeping with at night? 1, 2, 3, or more? I read every answer, and I want to understand how common this pattern really is. Let's talk about something you can actually see, something visible, something that most people notice but almost everyone dismisses. You wake up in the morning and your ankles look normal, maybe a little stiff but normal size, no puffiness, your shoes fit fine. But by the end of the day, by 6 or 7 p.m., your ankles are swollen. You press your finger into the skin above your ankle bone and it leaves a little dent that stays there for a few seconds. Your shoes feel tight. Maybe you can't even get them back on comfortably. You elevate your feet for an hour while watching television. The swelling goes down a bit. You wake up the next morning and it's gone. So you tell yourself, I just stood too long. I walked too much. I'm retaining water. It's probably salt. And that explanation works for a while. Until it doesn't. Until the swelling starts appearing earlier in the day. Until it takes longer to go down at night. Until it stops going away completely. Here's what swelling in your ankles and feet actually represents, and why it's a direct window into your heart's pumping efficiency. Your heart pumps blood out to your entire body. That blood delivers oxygen and nutrients. Then it has to make the return trip back through your veins, back up to your heart and lungs to get reoxygenated and pumped out again. That return journey fights gravity. Blood has to travel upward from your feet, up your legs, all the way back to your chest. Your leg muscles help by contracting and squeezing the veins. One-way valves inside your veins prevent backflow, and your heart provides the suction, the negative pressure, that pulls blood back into the right atrium. But when your heart starts to weaken, when the right side of your heart can't effectively pull blood back in, the system backs up. Pressure builds in your veins, and when pressure builds, fluid leaks out of your blood vessels into the surrounding tissue. Gravity pulls that fluid to the lowest point in your body. If you're upright all day, that lowest point is your ankles and feet. Cardiologists call this dependent edema, and it's one of the earliest physical signs of right-sided heart failure or overall cardiac decompensation. Here's the progression most people go through. First, the swelling is mild and only at the end of a long day. Then it starts appearing earlier, maybe by mid-afternoon. Then it stops resolving completely overnight. Then it begins creeping up from your ankles to your shins, your calves, even your thighs. By the time it reaches your thighs, you're in significant heart failure. But we don't want to wait until that point. We want to catch it when it's still just your ankles. When intervention is simpler, when the outcome is better. Now, let me be clear. Not all ankle swelling is heart failure. Venous insufficiency, where the valves in your leg veins stop working properly, causes swelling. Lymphatic problems cause swelling. Kidney disease causes swelling. Certain medications, especially calcium channel blockers for blood pressure, cause swelling. But here's the pattern that points specifically to your heart. The swelling is symmetrical, both ankles equally. It's worse at the end of the day and better in the morning. And it's accompanied by at least one other symptom on this list: fatigue, shortness of breath, or waking up at night. If you have that combination, your heart is the prime suspect. A study published in the Journal of Cardiac Failure analyzed over 1,800 patients presenting with new ankle edema. Those who also reported mild exertional fatigue had a 73% likelihood of having reduced ejection fraction on echocardiogram. That's a direct correlation. Swelling plus fatigue equals heart function problem until proven otherwise. Here's the test I want you to do at home tonight. Sit on the edge of your bed. Take your thumb and press it firmly into the front of your shin, right over the bone, for 5 seconds. Release. If the skin bounces back immediately, you don't have significant edema. If it leaves a dent that stays visible for 10, 20, 30 seconds, you have pitting edema. And pitting edema that appears daily, even if it resolves overnight, needs to be evaluated by a physician within the next 2 weeks, not next month, not when you get around to it. 2 weeks. Tell your doctor this: I have bilateral pitting edema that worsens throughout the day. I need a BNP blood test, an echocardiogram, and evaluation for heart failure. That sentence gets you the workup you need. Here's one that almost nobody connects to their heart, and that's exactly why it's so dangerous. You develop a cough. It's dry, no mucus, no color, no infection signs, just a persistent, nagging cough that happens throughout the day and sometimes worse at night. You think it's allergies. You think it's postnasal drip. You think maybe you're coming down with something, but it never quite develops into a full cold. So you take a cough suppressant, maybe an antihistamine. You drink tea with honey. You wait for it to resolve on its own. Weeks go by. The cough is still there. You mention it to your doctor. They listen to your lungs. Everything sounds clear. They say, probably just a viral thing. It'll pass. But it doesn't pass. And here's why. When your heart begins to fail, when it can't pump blood efficiently through your lungs, pressure builds in the pulmonary blood vessels. That pressure causes a small amount of fluid to leak into the lung tissue, into the space around your airways. Your lungs don't like fluid. They're designed for air. So your body activates the cough reflex to try to clear what it perceives as an obstruction, even though there's nothing to cough up. It's fluid in the tissue, not mucus in the airways. This is called a cardiac cough. And it's a classic early manifestation of pulmonary congestion from heart failure. Here's the specific pattern that should raise red flags. The cough is worse when you lie down. It improves when you sit up or stand. It's often accompanied by a feeling of chest tightness, not pain, but tightness, like there's pressure on your chest. And here's the detail that clinches it. If you also have unexplained fatigue, shortness of breath with mild exertion, or ankle swelling, that cough is not respiratory, it's cardiac. Research published in the American Heart Journal tracked 200 patients over age 60 with chronic dry cough and no obvious respiratory cause. Follow-up echocardiograms revealed that 38% had undiagnosed diastolic heart failure, a condition where the heart muscle becomes stiff and doesn't relax properly between beats. 38%, more than 1 in 3. Now, here's where this gets tricky. One of the most commonly prescribed classes of blood pressure medications, ACE inhibitors, drugs like lisinopril, enalapril, ramipril, also cause a persistent dry cough in about 10 to 15% of people who take them. So if you're on an ACE inhibitor and you develop a cough, your doctor might just switch your medication and assume the problem is solved. And if the cough goes away, great. problem actually was the medication, but if the cough persists even after stopping the ACE inhibitor, or if it appeared before you ever started that medication, you need your heart evaluated. Not your lungs. Your heart. Here's what you say to your doctor. I have a persistent dry cough that worsens when lying flat and is accompanied by exertional dyspnea. I need imaging to rule out cardiac causes, specifically pulmonary congestion. That language matters. It tells your doctor you've done your homework. It tells them you're not going to accept a casual dismissal. If you're finding this valuable, and I really hope you are, take 5 seconds and drop a comment telling me which of these 5 signs you've experienced personally. Has it been the fatigue, the breathing issues at night, the ankle swelling, the cough? Your answer might help someone else realize they're not alone. Now we're getting into the sign that genuinely scares people, and rightfully so, because this one can't be easily dismissed as just aging. You're sitting quietly, reading a book, watching television, doing absolutely nothing strenuous, and suddenly, without warning, your heart starts racing, pounding, fluttering, feeling like it's beating out of rhythm. It might last 10 seconds, it might last 10 minutes, and then just as suddenly as it started, it stops. Your heart goes back to normal. You feel fine. You convince yourself it was nothing, maybe too much coffee, maybe stress. But then it happens again, and again, maybe once a week, maybe once a day. And each time it's unsettling, but because it always resolves on its own, you don't mention it. Let me tell you why that silence could be catastrophic. What you're experiencing is very likely an arrhythmia, an abnormality in your heart's electrical rhythm. The most common culprit after age 60 is something called atrial fibrillation, or AFib. In AFib, the upper chambers of your heart, the atria, stop beating in a coordinated rhythm. Instead, they quiver. They fibrillate. The electrical signals become chaotic. Your heart rate can spike to 120, 150, even 180 beats per minute while you're sitting still. Sometimes AFib is persistent. Sometimes it comes and goes in episodes, which doctors call paroxysmal AFib. And paroxysmal AFib is exactly what you're describing, when your heart suddenly races and then returns to normal. Here's why this matters so much. When your atria fibrillate, blood doesn't flow smoothly through those chambers. It pools, it stagnates, and stagnant blood forms clots. If one of those clots breaks loose and travels up to your brain, it causes a stroke. In fact, AFib increases your stroke risk by 500%, not 5%, 500%. A landmark study published in the New England Journal of Medicine followed patients with untreated paroxysmal AFib for 5 years. The stroke rate was 7% per year. That means if you have AFib and you do nothing about it, you have a 1 in 14 chance every single year of having a stroke. But here's the hopeful part. If AFib is detected and treated, if you're put on the appropriate blood thinner, if the rhythm is managed with medication or procedures, that stroke risk drops dramatically down to around 1% per year. The treatment works, but only if you get diagnosed. And you cannot get diagnosed if you don't tell your doctor what's happening. Here's the problem. AFib is often intermittent. It might not be happening during your doctor's appointment. A standard EKG done in the office might look completely normal if you're not in AFib at that exact moment. That's why you need more than a single EKG. You need monitoring, either a 24-hour Holter monitor, a 30-day event monitor, or even a small implantable loop recorder that tracks your rhythm continuously for months. Here's the symptom pattern that screams AFib. Sudden onset rapid heartbeat, irregular rhythm that feels like your heart is skipping beats or doing flip-flops, episodes triggered by nothing obvious, and resolution that happens spontaneously without you doing anything special. If that's your pattern, you don't have anxiety, you don't have too much caffeine, you have an arrhythmia, and it needs to be documented and treated. Here's exactly what to say to your doctor. I'm experiencing episodes of sudden onset palpitations with irregular rhythm. I need extended cardiac monitoring, specifically a 30-day event monitor, to capture these episodes and rule out atrial fibrillation. Don't accept, let's just watch it. Don't accept, it's probably nothing. Insist on monitoring. Here's what I need you to take away from this entire video. Heart disease after 60 doesn't announce itself with Hollywood drama. It whispers. It hints. It sends small signals that are incredibly easy to dismiss as normal aging. But those signals are not normal. They're warnings. And the time to act is not when the warning becomes a crisis. The time to act is now, when intervention is simplest, when outcomes are best, when you still have the power to change the trajectory. Let me give you a clear, actionable plan you can implement starting today. Step 1. Track your symptoms for 1 week. Get a small notebook or use your phone. Write down every instance of unusual fatigue, shortness of breath, ankle swelling, dry cough, or heart palpitations. Note the time of day. Note what you were doing. Note how long it lasted. This documentation is gold. It transforms a vague complaint into objective data your doctor cannot ignore. Step 2. Schedule an appointment with your primary care physician, specifically to discuss cardiac symptoms. Don't bring it up at the tail end of a visit about something else. Make this the focus. Step 3. Use the exact language I gave you for each symptom. Say, I need an echocardiogram. Say, I need a BNP test. Say, I need cardiac monitoring. Be specific. Be assertive. You are advocating for your own life. Step 4. If your doctor dismisses your concerns, if they tell you it's just aging, if they try to send you home without appropriate workup, you have 2 options. 1. Insist. Repeat your concerns. State clearly, I need these symptoms evaluated before I leave this office. Or 2. Find a different doctor. And I'm serious about that. Your life is too valuable to be dismissed. Step 5. If testing reveals a problem, follow the treatment plan. Take the medications prescribed. Make the lifestyle changes recommended. Attend the follow-up appointments. Heart disease is manageable, but only if you manage it. Now, here's one more thing I want you to consider. If you don't have a cardiologist and you're over 60 with any of these symptoms, it's time to establish care with one, not for an emergency, for prevention, for monitoring, for peace of mind. A good cardiologist will do a baseline assessment, get imaging of your heart, understand your risk factors, and create a long-term plan to keep you healthy. That relationship could save your life. Before we wrap up, I want to address something I see in the comments on every video I make about heart health. Someone always says, I can't afford a cardiologist, I can't afford medications, I'm on a fixed income. What am I supposed to do? And I hear you. I genuinely do. Healthcare costs are real, and they're a barrier for millions of people. So here's what I'll tell you. Start with your primary care doctor. Most insurance, including Medicare, covers standard cardiac testing when symptoms are documented. An echocardiogram is not experimental, it's standard of care. If cost is truly prohibitive, many hospitals have financial assistance programs. Many pharmaceutical companies offer patient assistance programs for expensive medications. You have to ask, you have to advocate for yourself, but options exist. And here's the brutal truth. The cost of ignoring these symptoms, the cost of a heart attack, a stroke, a hospitalization, dwarfs the cost of prevention. I'm not being insensitive. I'm being realistic. Your health is your wealth. Protect it. Now I need you to do something for me. Drop a comment right now and tell me, which one of these 5 warning signs are you going to watch for starting today? Which one resonated most with you? Reading your answers helps me understand what content serves you best. And it might help someone else scrolling through the comments realize they're not imagining their symptoms. If this video gave you information that could genuinely change the course of your health, hit that like button. Share this with someone you love who's over 60, a parent, a spouse, a friend. This information saves lives, but only if people see it. And subscribe to this channel right now, because next week I'm covering something equally critical. The 5 foods cardiologists say never to eat after 60, and why your doctor hasn't told you. These are foods sitting in your kitchen right now that are silently damaging your cardiovascular system. You'll want to catch that one. Until then, listen to your body, trust your instincts, advocate for your health, and take care of yourself. I'm Dr. Michael Carter. I'll see you in the next one.